Hello, good morning, everyone. Good afternoon or good evening for those joining us from different time zones. My name is Ciani. I'm the Medical Education Manager at the WFH. It's a great pleasure to welcome you to today's webinar entitled Comprehensive Pain Management in People with Bleeding Disorders. Thank you so much for taking the time to join us today. We are very excited to have such an outstanding professional with us, and we look forward to a great section together. So before we started, the webinar, I would like it to show you how you can choose your language. So we have an interpretation in Spanish today. So if you would like it to change the language, if you're using a cell phone, there is 3 dot here that you can click. You have to click in the language interpretation, and then you have to choose the channel that would like it to listen us. If you're using a computer, sometimes you have the interpretation button here or the 3 dots. Click, and then you have to choose the channel that you'd like it to listen us. Okay, so here is the agenda for today. We are going to have the introduction with Carla D'Afuncio and the moderators. And the first presentation will be Thomas Ilberg. The second panelist will be Hortensia de la Corte Rodriguez. And the third one is Carlos Cruz Montesinos. Of course, we will have a question and answer open following the end of the presentations. Just remind you guys, we have put all the participants on mute. And if you have any questions, please go to Q&A box and text your question there. We are going to discuss in the end. Here the disclaimer, the WFH does not promote any particular pharmaceutical product, and any mention of any commercial brand in this presentation is strictly for educational purpose. Welcome, Dr. Assad. It's my pleasure to introduce the Director of Humanitarian Aid and Medical Training, Assad.
Thank you very much, Cian, for the introduction. And really, I'm quite pleased today to be on this webinar, welcoming all the participants. And I would like to take this opportunity to thank our musculoskeletal committee at the WFH, particularly Carla, the chair of the committee, who was instrumental in the organization of this webinar. Having said that, this is, I know, the end of the year, and this probably is going to be the last webinar we're going to do. But in our collaboration with the MSK committee at the WFH, we promise our participants that we're going to have more webinars on the musculoskeletal aspects of hemophilia care in 2026, because this is the way that we used to do in the past with all our MSK committees that I lived with for 25 years. So welcome again. And at the same time, I would like to thank the two people who were behind the organization of this. I would like to start with thanking my colleague, Dr. Jason Martin, who is the head of our medical training at the Humanitarian Aid Department, and Mrs. Cian Souza, who is our medical education manager. Without the help and the dedicated work of these two, this webinar wouldn't have been possible today. Thank you very much. And I'm going to give it back to Carla to welcome you and start the webinar. Thank you, Carla.
Thank you, Assad. Good morning, good afternoon, and good evening to everyone joining us today. On behalf of the Musculoskeletal Committee, I would like to express our deepest gratitude to the speakers moderators, and humanitarian aid for making this event possible. We also extend a sincere thank you to all of you for your commitment and interest in this webinar. Today's session addresses an important topic, pain in bleeding disorders. Our comprehensive agenda will delve into the underlying causes of pain, pharmacological treatment strategies, and how to safely implement effective strength training for people with hemophilia with arthropathy. Now I introduce our moderators, who will present the speakers and manage the agenda and questions and answer session following the presentations. They are Greg Blamey and Dr. Mohanty. They are a very well-known musculoskeletal professional, and surely most of you know them. Greg is a consultant physiotherapist with the Adult Inherited Bleeding Disorders Program of Manitoba in Winnipeg, Canada, since 1997. Former chair of the Musculoskeletal Committee, and he is also the distinguished 2025 Pietro Grande Prize winner. Dr. Mohanty is a professor in orthopedics who works in the King Edward Memorial Hospital in Mumbai, India, associated with care of people with bleeding disorders in 1998, and he is the winner of the Henry Orosowski Award at the 2025 Congress in Dubai. To all of you, thank you again for your participation and engagement. Enjoy it. Que lo disfruten.
Thanks very much, Carla. I'm going to turn the mic over to Dr. Mohanty in a minute or two to do the speaker introductions. I'm looking at my screen. It looks like we have just shy of 100 participants so far, which is great. As Siani said, for questions that you want to ask while the presentations are going on, we are going to hold all of the questions until the end, until all three presentations have been done. But you can type your questions into the Q&A. You can type your questions in English or Spanish. And Dr. Mohanty and I will be tracking the questions and directing them to individual speakers. Undoubtedly, there will be groups of questions. We can't get to every question with so many participants, but the session is being recorded, and the WFH MSK committee can use this recording going forward to look at those questions, use that as a way to plan future webinars and conference sessions. So please make sure that you do type in your questions, and we'll get to as many of them as we can. So Dr. Mohanty, do you want to introduce the speakers?
Sure. Thank you, Greg. And good morning, good afternoon, good evening to you all. And we have an eminent panelist. First, let me introduce Professor Thomas Hilberg, who is a chair of Department of Sports Medicine at the University of Wuppertal in Germany. He's a physician and specialist in general medicine, sports and rehab medicine, as well as qualification in osteopathic medicine. He has more than 25 years and has focused his hemophilia research on synovitis and arthropathy and sports therapy, as well as pain in hemophilia. Welcome, Professor Hilberg. And next speaker is Dr. Hortensia de la Cas Rodriguez, and she is a specialist in physical medicine and rehab at La Paz University Hospital in EDIPA's Institute of Health Research in Madrid, Spain. He holds a PhD in coagulopathies and is in charge of rehabs, reference rehab at her center with expertise in prevention, diagnosis, and treatment of MSK problems with special focus on pain and disability. Extensive experience in the use of point of contact ultrasound and certified as a head ultrasound trainer since 2015. Welcome, Hortensia, to this webinar. And finally, Professor Carlos Cruz Montesinos, he's a professor of physical therapy at University of Chile with a joint PhD in movement sciences and physical therapy. His research focuses in hemophilia care, biomechanics, motor control, and rehab. And he's a board member of Chilean Society of Hemophilia as well. So welcome, Carlos, and welcome all of you. And let me hand over to Professor Thomas Hilberg to deliver his first lecture.
Okay, thank you. I will transfer the control for Dr. Thomas. And you can try to see if you already have it.
Can you hear me and see me well?
Yes.
That's fine. Okay, then I can start. Many thanks to all the organizers there and also for the invitation there, the WFH and the MSK committee and Carla as well, to give this talk today. And it's absolutely a pleasure to speak about the relevance and the causes of pain in people with hemophilia. And this, I can't go further on. It's not possible to go further on.
Try to move your mouse, please.
Yeah, I see the mouse, the cursor.
No,
But
not
it's
yet.
not possible to move the slides. I'm sorry.
Okay. I can do it for you.
So next slide, please. These are my disclosures, and we can go to the next one. And I want to address today 3 different questions. I want to give an answer to the question, why is pain relevant in people with hemophilia? What are the causes and locations of pain? And which mechanisms are significant for pain? Okay, go further on. And this, I think we speak about pain today, so it's necessary to define it a little bit. And this is the definition here of the International Association for the Study of Pain. And they define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And acute pain is a warning signal for us. It's important. However, chronic pain becomes very, very often an own entity, especially when it's lasting a little bit longer, for example, longer than 3 months here. And then it's maladaptive and it significantly affects quality of life. And this is what we can see in the next slide, because this is an overview here about known study where we have investigated, where we did a systematic review there to look after the point prevalence. And what we can learn from this publication here is that in 75% we have a point prevalence of pain there in people with hemophilia. And go further on. And if we ask about chronic pain, we see more than 40% have chronic pain. And this is in line with a meta-analysis from Paredes et al. And we can go further on. And what we can see that this is associated with the interference with activities of daily living. So to answer this question, it's clear that pain is absolutely relevant in people with hemophilia. Okay. So let us switch to the second question. What are the causes and locations of pain? And we can go further on. And this is a study here where we investigated, where we ask 300 people with hemophilia about the most frequent pain source. And the answer, and there were multiple answers possible. The answer was in 32% that the ankle is the source. And in 20%, the knee, and in 50% the elbow. So the hemophilic specific joints were the most pain source, the most frequent pain source, although we had found other sources there. Go further on, which we also can see in the population without hemophilia. But at the end, to bring it to the point, the most frequent pain source are the hemophilic joints. Okay, go further on. And so we go directly to the joint, and this on the left is a healthy joint. We see the bone, we see the synovial membrane, we see the cartilage there. And if acute hemarthrosis is present, as well as recurrent hemarthrosis is present, we have a change there, go further on, of the bone, of the synovial tissue, in respect of synovitis or cartilage degeneration. At the end, we have the full picture of hemophilic arthropathy. So, and what we have addressed in another study was, what are the main causes there for pain inside this pathological process? And this we can see at the next slide, please. And from this investigation, we could see that especially osteophytes, changes there of the bone and changes of the synovial tissue are reasons for enhanced pain sensitivity. And the background of this thickness of synovial tissue is synovitis. Okay, so from this, we could say that the most reason is coming from the joint directly, coming from special tissues there of the joints. And so we can say that this is a nociceptive pain, because nociceptive pain is a pain that arises from actual or threatening damage to neuronal tissue, in contrast to neuropathic pain, which comes directly from the neural tissue. But to distinguish between nociceptive and neuropathic pain, we did another study, which I can show at the next slide. This is a system here. The Pain Detect is a patient-based questionnaire, which is able to distinguish between neuropathic pain and non-neuropathic pain. And we use this patient-based questionnaire to distinguish between these two entities. What we can see here that in 6.6% out of 137 people with hemophilia was positive and the other was negative. And from this, we can postulate that in the many cases, it's more a nociceptive than a neuropathic pain cause in the background, because these types of pain have to be treated differently. So this is important to know where the pain is coming from. Okay, so going to the next slide. And these are the mechanisms. Which mechanisms are significant for pain in the background? And let us have a look, and we have different stages there. We have of pain processing. We have the nociceptors directly there in the joint, for example. We have the spinal cord, and we have the brain. We have a transduction, we have a transmission, and we have a perception. So let us go directly back to the joint and seen in the next slide what happens there inside the joint, inside this area there of nociceptors. And this is an example here how inflammatory cells are able to trigger pain processes there, to release, for example, the next slide, special inflammatory molecules there. And we know these molecules there from the situation there, hemophilic arthropathy. And these inflammatory cells are able to release these different molecules. And for example, TNF-alpha activates the TNF receptor of a nociceptor. And with this change the threshold there of a natrium channel. And in a chronic, in acute process, this will end after the distribution there of these molecules. However, during chronic processes, we have a sensitization there of this nociceptor, and this is one point of chronification of pain. This is the first stage, the first level. Let us switch to the second level. Before we do this, we look a little bit, there are different molecules where we know that they might sensitize primary nociceptors. On the other side, there are also some molecules which are able to reduce the sensitivity of primary nociceptor. And this is important to know because this is a part of chronification of pain, directly there inside the nociceptor. Let us go further on to the next step. And the next step is the dorsal root neuron there in the spinal cord. And also in this area, what we see here is the switch, the synapse there between the first order neuron and the second order neuron. And also there is a release there of different inflammatory molecules induced by T cells, by microglia cells, and so on. And it's the same situation there in the chronic phase, in the chronic pain situation, that the threshold there is decreased there over time during this chronification process. And this is important for us to know because it's also one part of chronification. This is and the dorsal horn neurons we know become hypersensitive there. One example is the NMDA receptor, for example, which results in hyperalgesia. Okay, this is the second stage, the second level. Let us switch to the third level, and this is the brain itself. So because the brain itself, we know that chronic pain is associated with less gray matter volume in different areas there inside the brain. And this is important to know because this is a bad news. However, on the other side, we have on the next slide also a good one because the brain gray matter decrease in chronic pain is the consequence and not the cause of pain. So we have options to reduce this if we are able to treat pain successfully. So it is in partly reversible, this process. Okay, this were three different stages, but we have another part there in the system. This is also important because, and this is called descending inhibition. And this descending pain modulation from the midbrain inhibits a little bit, has an inhibitory control, and is able to reduce pain sensation. However, if you have a constantly firing receptor there, then it is hard to control this. And we know that also this descending inhibition is changed during the chronification process. And this is what we have investigated also in a study. We next slide, please. We investigated there this descending pain inhibition in people with hemophilia, and the results of this study could show that people with hemophilia suffered from an impaired degrees of this endogenous pain modulation in comparison to healthy controls. So we can suggest that this has also a special role there in the chronic pain situation, I hope this was not overwhelming, the different mechanisms. And I try to come to my conclusion and want to show this conclusion very briefly and of an easy way. So at the end, pain in people with hemophilia, and this is what I have to try to show during my first part of my talk there, is definitely a burden for people with hemophilia. And where does it come from? It comes primarily from nociceptive elements there. It's nociceptive, especially in the affected joints. And at the end, the chronification process might concern different levels of pain perception. It is less addressed in people with hemophilia because some of these results were transmitted from other joint diseases, from other chronic joint diseases as well. So this is important to develop more studies there, especially in this processes of chronic changes there in pain perception or pain processing. So what is our aim and goal at the end of this research and at the end of this processes here? We try to reduce pain, in the best case to have painless people with hemophilia, becoming old with a smile on their face. Thank you very much for your attention.
Thank you, Dr. Thomas. I just would like it to remind everyone we have interpretation. So if you would like it to listen in Spanish, please choose the Spanish channel. If you keep it in English, you can choose English channel. Okay. So Dr. Hortensia, I think I transferred the control to you. Please double check if you have the control already. Yeah, it's you, not me. I think you are mute. Hortensia, you are mute. Okay, let me remove. Maybe you cannot change your audio. Okay, can you change your audio now?
Yeah, now.
Okay.
With the control, I couldn't find it. Thank you, Chef.
Okay. Okay, I transfer again.
So sorry, and thank you for the invitation to be part of this webinar. During the next minutes, I will try to share an overview about a pharmacological treatment in hemophilia. Well, now I cannot pass the
Yeah, it's you that is
presentation.
passing
It's
the
me?
slide.
Okay, here. It has a little delay. Okay, let me start, sorry, by saying that assessing pain, which includes not only its intensity, but also its functional, emotional, and social impact, is essential for guiding effective treatment. Pain management in hemophilia must be individualized and multimodal, as you can see in this slide. This involves, of course, the patient, but also a large number of healthcare professionals. And among all the cornerstones of the multidimensional approach, now in these presentations, we are only to talk about pharmacotherapy. And in terms of the different ways of drug administration, we will discuss those administered orally, painkillers, and intraarticularly. Why is a medication used to treat pain? Well, according to World Health Organization, we can say that 95% of the painful syndromes of any etiology are perfectly treatable with proper use of conservative pharmacological therapy. Therefore, promoting the use of analgesic reduces the effect of pain and functional limitation. At this point, we can also remember that hematological therapies have been shown to reduce chronic pain as well, possibly by controlling microbleeds. So, if possible, please always ensure hemostasis control before treating pain. And keep also in mind that we must be, in some cases, the first line to the initial approach to our patient's pain. So, as Thomas mentioned before, it's important to understand the differences between the types of pain, because more than one type of pain can be present in our patient. Pain can be nociceptive, neuropathic, or sensory hypersensitivity, what is known nowadays as a nociceptive pain. Nociplastic pain. And this nociplastic pain is due to central sensitization of pain. And why is this important? Because it is well known that untreated pain can become chronic and centralized, brain centralized. And this central sensitization of pain is more difficult to treat because it's associated with neurobiological, psychological, and social changes that perpetuate it. So prevention and treatment of pain is mandatory. Treatment should be planned after assessment with regular dosing intervals, including rescue medication. We know that an approach using combination of different drugs that act on different metabolic pathways is preferable, as it can improve analgesia and reduce side effects. It is also well known that without medical control, some patients misuse painkillers or use other pain relievers. So we should avoid this risk. Then how can we treat it? How can we treat pain pharmacologically? Here we can see the analgesic ladder published by the World Health Organization. As you can see, there are 4 steps depending on the intensity of pain. The first includes paracetamol, metamizole, and anti-inflammatory drugs. The second, minor opioids, tramadol, codeine. The third, major opioids. As you can see, there are many. And the 4th steps are the invasive procedures. And what about hemophilia? Well, the recommendations for hemophilia are derived from this ladder, but with some important changes that we should keep in mind, that mainly are that anti-inflammatory drugs should not be used. except those that are selective cyclooxygenase 2 inhibitors, and these drugs are moved to the second step. Here we can see better the adaptation of the analgesic ladder recommended in the last guidelines from the World Federation of Hemophilia. And regarding the second step, you can see that among COX-2 inhibitors, celecoxib, meloxicam, and nimesulide are mentioned. All are equally effective in terms of relieving pain, but celecoxib is the most selective of COX-2 inhibitors, so that it has the lowest gastrointestinal risk and the least hepatotoxicity. And there's no mention for the fourth step. In addition, we know that COX-2 inhibitors in fact promote platelet aggregation, which is beneficial for people with hemophilia, and reduce gastrointestinal effects compared to COX-1 inhibitors. However, they increase the risk of coronary events, which should be taken into account in patients with cardiovascular risk. And we must also remember that all anti-inflammatory drugs, both selective or not selective of COX-2 inhibitors, have similar risk of renal, hepatic, hypersensitivity, or central nervous system effects. Therefore, in people with liver disease due to chronic hepatitis C, something frequent in people with hemophilia, liver function should be carefully monitored if we use these drugs, and if possible, please avoid nimesulide. In general, our recommendation is to use anti-inflammatory drugs just in short cycles and the less as possible and for acute pain. What about second and third step? We know that these drugs are effective to control pain, but have adverse effects such as nausea, constipation, sedation, and so on, which, although reversible, often cause patients to stop taking them. The management and conversion of these major opioids is not easy, so we must be well trained in their use before offering them to our patients. In fact, we have to say that recently there has been some reluctance to prescribe opioids for chronic pain due to concerns about abuse and addiction. We all can have in mind the terrible crisis with opioids, and particularly in the United States, the FDA has recommended opioids formulation that reduce the risk of misuse, as you can see some in the slide. And we can ask, then, is there any alternative when the pain is intensive? Well, in fact, there's an alternative that could be to introduce minimally invasive procedures in the third rank and use or push up major opioids as the last resort. These techniques may be indicated in people with hemophilia who suffer from local pain, as can be a joint pain. And of course, they are not used for generalized pain. And also, it can be used in those patients who do not respond to other conventional therapies. So these procedures is not the first line of treatment. Ultrasound guidance can help us to ensure intraarticular placement of the needle tip while minimizing injury to the periarticular soft tissues. These more precise approaches are also preferable when we want to avoid puncturing, for instance, synovitis or critical neurovascular structure, or even those osteophytes typical of arthropathy, and so on. These techniques should always be performed with proper hemostatic coverage and all the aseptic standards, well coordinated with dermatologists and nurses. And with this condition, no septic arthritis has been reported in literature. The most commonly used procedures in hemophilia are those applied to the elbow, knee, and ankle to treat bleeding, to treat synovitis and to treat that pain typically of arthropathy. To treat hemarthrosis, joint aspiration has been shown to accelerate pain recovery and joint function and reduce the use of a coagulating factor. For synovitis, synoviorthesis reduces the rate of joint hemorrhages up to 70% and decrease the use of clotting factor as well. We can use radioisotopes or chemical products. Corticosteroids also offer a short relief of pain during a long 6 weeks. And there are other new drugs like platelet-rich plasma that seems to also improve pain. And it's a promoting drug, but we need further studies. And lately for arthropathy, for that pain, analgesic injections improve pain and joint function. There are more evidence with hyaluronic acid, but there's also others like PRP or anesthetic for nerve blocks, radiofrequency, and so on. So to conclude, finally, we can say that different pharmacological options to treat pain exist in hemophilia. They are all part of a multimodal approach. And it is essential to improve knowledge and coordination between patients, the multiple professionals involved, and health system to improve pain management in people living with hemophilia. And this is the end of my presentation. Thanks for your attention.
Thank you very much. Now I will transfer the control to Dr. Carla Cruz, and you can...
Okay, I will try to pass the slides. I can't.
Yeah, you can start to try. There is a small delay, but you will be able to do it.
I can, so you can help me, okay?
Yeah.
Okay, perfect, thank you. So my talk is about strength training in arthropathy. Next, please. Next slide.
It's you.
I can't. This is my point. No.
No, okay, I will.
No.
I can do
Okay.
it.
Okay, thank you.
Oh, wait.
Okay. So we will talk about 3 topics. The first one is how the muscle protect joints. So we will talk about the mechanisms that explain how muscle can help. And second, the prescribed strength training in people with arthropathy. And finally, I will talk about a case report of strength training in a severe joint damage.
Right.
Okay, how the muscle protect joint? We need to understand there are not a single mechanism. So we need to understand that muscle could help to force absorption, and this could be attenuate the impact during daily life activity. And also we have the neuromuscular control. So muscles, when activate, mainly the agonist-antagonist muscles, can help to balance the co-contraction and give stability to the joints. And also, anytime that we do, anytime that we do exercise or movements, the muscle can release molecules that the name are exocrines that can help like an anti-inflammatory effect and also could help to the cartilage homeostasis and synovial lubrication. So these are the 3 main mechanisms that explain how the muscle protect joints. The next, please. So when we talk about the neural control, we need to think that there are optimal co-contraction, and this optimal co-contraction depend on the muscle hypertrophy, the strength of the muscles, the endurance, the pain control, and the proprioception. So you can see also a difference of control between one individual of normal neural control gait, and in the other side, you have an altered neural control gait in one patient that have all muscles activated at the same time around knee, hip, and ankle. The next one, please. So we know already that the increased contraction of the knee can be associated with the greater progression of knee arthritis. And also we know that the strength training is associated with less knee osteoarthritis, and the gain between 30 to 40% in strength is associated with meaningful improvement in pain and function. And in hemophilia, we know already that there are a very nice article that when you combine aerobic and strength exercise in adult with hemophilia, we can see a reduction of inflammatory cytokines and increased anti-inflammatory markers like interleukin 10. So what we know also in hemophilia, when we do a strength training, based on this systematic review that included 7 studies with no adverse events, we found, the next, please, we found that the benefits of enhance of muscle strength could be found after or from 5 weeks with a frequency of 2 to 3 times per week. And the increase can be in the range between 9 to 31%. And the other message of this article is important to understand that you can find increase of strength using an elastic band resistant exercise and also with a machine, typical machine approach. So this is important because at the end you can use a simple band elastic resistant in your house if you want to strengthen your muscles. And the other point, when we try to prescribe strength training people with hemophilia, is the pain. And this is important because if the patient does not find a certain form of exercise acceptable or safe, the results are likely to be limited. So for this approach, we need to think that we have some thresholds to do a strength training. A safe threshold could be like 0 to 2 of intensity of pain, and acceptable threshold will be between 3 and 5. And this is also important because if the patient perceives too much pain, like more than 6, could be also a psychological stressor. So we need to think in mind that sometimes it's not necessary to stop doing the exercise. You can change the exercise, you can change the intensity of the exercise in a acceptable threshold or also in a safe threshold. So also based on this study, we also observed that each week of strength training with an increasing progression of intensity every 2 weeks, we found, next one please, we found the patient can enhance the perception of functionality and functional skills, and also the quality of life, but mainly the dimension of the joint health perception. The next one. But in this study, we observed a limited effect on mental health and social relationships. So that means that we need to keep in mind that strength training alone can be helped in functional perception of patient, but not in social relationship and mental health. So for that, we need to combine with other approach like education or psychological professionals. The next one, please. And we need to keep in mind also that there are a lot of variables that we need to keep in mind when we prescribe strength training in people with hemophilia. This is also another article where we observed that the main clinical trial in hemophilia do not report a key variable like prophylactic factor coverage, pain threshold, intensity of training, range of motion, and time under tension. So in this checklist, you can see summarize the minimum information that we need to report it, not only when we do some study, but also when we prescribe strength training in people with hemophilia to improve the safety and also the comparability between different studies. And finally, I will show you a case report of strength training in a severe joint damage. So here is the patient, as you can see, have a severe joint damage in the knee and also a muscle atrophy in quadriceps. The next one, please. And here you can see the active range of motion and the intensity of pain that was 6 and also the same intensity during daily life activity. So in this case report, we use the strength training with biofeedback using a device that you can connect with your smartphone. So the patient can see the signal of the force at the same time of the training. So we prescribe the intensity to load adjust to the pain intensity no more to 5. And the intensity was 80% of maximal voluntary isometric contraction with 4 sets to 10 repetitions with a 3 seconds of hold, with 2 minutes of rest, which is set, 2 sessions per week for each week, and always with prophylaxis at the same days of training. So here you can see how an example of one contraction with the biofeedback in this case report. So we observed in this case after 8 weeks an increasing of strength in 68%. But of course, there are a significant difference between the contralateral leg. But the important message here is if you have a severe joint damage, also it's possible to increase the muscle strength. And you can see here the active range of motion before and after. As you can see, for the patient, the possibility to active the muscle is better, and also showing a decrease of pain during active extension of knee and during daily life activity. And of course, the muscle size still be the same. So this is important message. You can increase your strength without to increase the muscle size. Only about the neural factor of strength. So also we did a follow-up of 2 years. So here you can see the gain of the strength after 2 years. So this is important because you can monitorize the strength month by month. In this case, because the patient are waiting for a total knee replacement. So this is important, a very important step for physical therapists, and also to try to improve the outcome after surgery. So the final take-home message, the first one, we need to understand the strength training is not a single mechanism. It's associated with clinical outcome in regard to the mechanical, neural, and endocrine integration. The strength training should be considered a key non-pharmacological therapy for pain and function, along to appropriate prophylaxis. And strength gains can be achieved even in severe atrophy. Thank you very much for your attention.
Thank you. I will pass this. Now it's time for our Q&A box. So the moderators, please.
Okay. I want to first of all thank all 3 presenters. I had complete confidence that these 3 expert presenters would have no trouble delivering clear information within their established time limits, and they did not let me down. And that makes moderating a multinational, multi-presenter session with a chat box in 2 languages much easier for me as the moderator. So thank you very much to Thomas and Hortensia and to Carlos for such clear and informative presentations. We do have some questions that have been coming in through the chat box, and so I'm going to start off with a question for each of the presenters. I'm going to give you, all 3 of you, your questions first, and then I'll ask you for your answers. And Thomas, you're going to get less time to prepare than the other 2, because I'm going to come to you first, and then Hortensia, and then Carlos. The questions that have come in, and I've kind of massaged the questions and added a little bit of my own queries into them. So Thomas, for you to begin with, there was a question about whether or not chronic pain development is different in pediatric patients or in adult patients, depending the age of the patient. Does it change how chronic pain pathways develop? And is there a way to strengthen the descending inhibition pathway? So that's going to be yours. Hortensia, there is a question about, do we know what the frequency of opioid addiction is in hemophilia patients or chronic pain patients? I know there's a lot of data available about opioid addiction, but do we really know what the rates of addiction are in chronic pain patients, particularly with hemophilia. And I'd also like you to weigh in on what you feel is the impact on mental health with either long-term use of a less potent pain medication or even a shorter episodic use of a more intense opioid. And Carlos, the question for you relates not only to strengthening, but to kinesiophobia and just the fear of movement and how that relates to pain. How can we prevent our hemophilia patients from becoming afraid to move because they have such a significant pain experience? And also for you, does that change with pediatric versus adult patients? So I can repeat those questions when I come to you. But the first question, Thomas, is to you about the difference in pediatric and adult patients and the way that chronic pain develops. Thomas.
This is absolutely a good question, and it's indeed different. It's indeed different in respect of asking about pain, because we know that in pediatrics, it's different how to ask about pain, how they can describe pain. So we have to use other questions, and we have to use sometimes other scales. Therefore, for example, there exist some scales which are in use for pediatric patients. And we go on, also the treatment is different. And there's only one aspect of treatments, the drugs are different, for example. We have some drugs which are not allowed, for example, in pediatric patients. So to bring it to the point, it's absolutely different, and we have to develop our experience in the direction of kids, pediatric patients, as well as in the other, especially in departments where we have both. So to bring it to the point, it's indeed different. It's different in asking, it's different in diagnostic, and it's different in treatment as well.
Okay. And the descending inhibition pathway, do we have ways to really directly impact that mechanism?
This is also an excellent question. Now, we have no data yet if we can change some different stages, some different levels of pain processing solely. So what we do at the end is we address the whole processing by our therapy. For example, this is the reason why we use the multimodal therapy, which includes the medical part, the psychological part, and the physical part. And this is what we have spoken a little bit about, Hortensia, about the medical part, that we have to give a sufficient treatment there from the medical side. Carlos has addressed it from the physical side. So at the end, to treat chronic pain, it's a complex situation, and we use all these opportunities there of a multimodal therapy, and we have to start with this very early, not too late, not after a long chronification process.
Perfect. Thank you. Hortensia, let me turn to you. What do we know about the actual rates of addiction, opioid addiction in hemophilia patients or chronic pain patients? And could you also maybe give us a bit of a comment on how you feel the use of these agents, pardon me, might impact the mental health of our patients?
Well, Greg, it's a difficult question. As far as I know, there are not clear rates about the percentage of addiction of opioids in people with hemophilia. There are some estimation in general population that the risk to be addicted when you use this kind of strong opioids is around 3 and 10%. But this data it is supposed to be extrapolated to hemophilic population, but it's not clear and it's not published. And about the mental health, well, it's also difficult. Of course, pain impact directly on the mental health of people with hemophilia. They live with more anxious, more depression. less quality of life, and this is very important. And if moreover they get addicted to opioids, of course this can even more impact their lives. But I don't have clear information about how opioids influence the mental health of patients. But clearly, it is like the rest of the population. It's terrible if someone, hemophilic or not, can become addicted to this type of medication.
Thank you. And Carlos, we have 111 people by my computer screen attending this webinar with us. What can you tell us about how we can address when our patients tell us that it hurts to move, right? How do we prevent kinesiophobia? Our patients have pain. We want them to be able to be active and exercise, but how do we guard against pain causing kinesiophobia? And does that differ when you're working with a pediatric patient or with an adult patient?
Okay, thank you. It's a great question. I think that the first one, the most important thing is the education for the patient. So when we say education, we also need to start asking for patient about the previous experience doing exercise, because sometimes the patient have bad experience doing exercise, like acute event of hemarthrosis or other type of this type of event that will be have a very bad history in the life of patient. So knowing the history of patient, the experience of exercise, then we need to educate about what are the benefits of doing physical activity and exercise, and also try to know the history of prophylaxis, because sometimes the patient don't know about when we need to prescribe the prophylaxis, in the morning, in the afternoon. So in my case, I always say to patients, try to combine the prophylaxis before to start the exercise. So this is a very few step. And then we need to also keep in mind the progression of the exercise in regard to the intensity, volume per week. So in this three way, like education, prophylaxis, and progression, we can try to convince the patient that the exercise will be a safe way to improve the overall health. Okay, and in regard to children, I think that we need to separate the world of the children, because yes, in some way you need to combine games with exercise to gain strength. But in adolescent, for instance, you can use like a weighting exercise. But in this case, I propose to use elastic band resistance because it's very safe, and the intensity of the exercise will be increased like with low load of exercise, like 30% of maximal voluntary contraction, for instance. And you can monitor the intensity and fatigue during exercise, because there are also a lot of study in osteoarthritis that the effect of functionality when you compare the low intensity with high intensity are mainly the same effect. So that means it's not necessary to do high intensity of training to improve the functionality. So in this way, you can do a safe exercise even in adult and children or adolescents.
Great, thank you. Dr. Mohanty, did you want to step in and ask a question of our presenters? I'm going to keep looking through the Q&A box here.
Excellent presentations. Personally, at least I could educate myself a lot of things from all these three speakers. So certain questions, let me come back to Thomas. Thomas, why do you think ankle is the most painful joint in PWH, and not the knee is the commonest joint to get affected, but why ankle in your study is just an observational finding, or is there any reason to tell that?
It's also a good question. It's depending on the prevalence or incidence of hemophilic arthropathy at the ankle joint, because there is a switch from the knee joint a little bit to the ankle joint. And with this switch, we have to focus a little bit more on the ankle joint, and this is the reason. The ankle is for itself a very, very complicated joint. It's the upper part, it's the lower part, and there is a lot of weight there on a small area there of bone. So, and on the other side, the ankle is also we know that the ankle is a joint of trauma, and we have a lot of ankle strains there and supination trauma with this, and all this together lead to I think a stress on the synovial tissue there. And with this first stress on the synovial tissue, we have a progress there of synovitis, and then a change to hemophilic arthropathy there in the ankle joint. And I think this is the reason why it is the patients with hemophilia are suffering from ankle problems there, and this is our experience. Maybe it is in the different countries they have different results, but from our knowledge, from my experience, it starts with the ankle joint, and in many cases of our patients, we have issues with the ankle, and this is the background.
Great. Yeah, I think I have personal observation also. Ankle becomes more painful. Though patients with knee deformities, they continue to walk with very bad deformities, but when ankle is affected, they become more painful. Thank you for that. Let me come back to Hortensia. No, Hortensia, I have a lot of questions for you. Though WFH recommend to start with paracetamol as the first line of treatment, in your slide you started with COX-2 inhibitors. Any particular reason that why you recommend that COX-2 inhibitors with the first line of treatment?
Well, maybe I didn't explain well. First line is paracetamol, metamizole, non-anti-inflammatory, inflammatory drugs. But this is for the general pain ladder for the World Health Organization. Not for me. For World Health Organization, anti-inflammatory drugs are in the first step. But for hemophilia, the recommendation is to push them up to the second step, precisely because of the hepatotoxicity and other effects. And in the case of using anti-inflammatory drugs, just COX-2 cyclooxygenase 2 inhibitors should be used, not the other ones.
And amongst the COX-2 inhibitors, in country like India, we get etoricoxib is the commonest drug which is available. We don't get celecoxib in India. So do you think etoricoxib is also equally effective? Because we prescribe to our patients etoricoxib.
Yes, I do. We are also using etoricoxib. It's the same family drug than celecoxib, so coxibs, also selective of cyclooxygenase 2, and it's working really good. But we have to keep in mind the cardiovascular effect that are in this type of drugs, etoricoxib especially, but celecoxib as well. So short cycles of this kind of anti-inflammatories are recommended.
So you need to avoid in people with cardiovascular conditions that you need to avoid COX-2 inhibitors. Do you have any experience of using this local anesthetic patches, like lidocaine patch, which helps in a local pain relief? Like you can apply in the joint, and that takes care of 24 hours pain, and you can mobilize the joint. And this has recently come to our country, and we all are using these local anesthetic patches.
Yeah, we have some experience, but mostly in people that have especially neuropathic pain. There's more evidence in this type of pain. But using it in joint pain could be useful in terms of facilitating mobilization and reducing synesthesia and so on. But we don't have many experience using it in hemophilic joints. And also they are not, well, they are expensive also in Spain. So no clear evidence and very expensive. We don't use it too much and not experience in a joint of hemophilic patients so far.
Okay. Let me come back to intra-articular. How do you see aspiration of a acute bleed reduces the pain and early mobilization? Though WFH doesn't recommend it's probably more helpful in tertiary care centers with adequate factor available. So, do you do routinely aspiration acute bleeds once aspiration
Yeah. Well,
to
as far
take
as I
care of the pain?
know, the World Federation of Hemophilia do recommend it for TENS hemarthrosis. For those big hemarthrosis is recommended. So this is the indication, an hemarthrosis that it's very painful, that it's not well controlled with clotting factor, and when the blood is liquid and you have all the conditions, the hemostatic coverage and the aseptic conditions, it's recommended to use it, and it's working very well. We have publications, and there are others that clearly it accelerates the recovery of the joint because, well, obviously you remove all the blood inside and it's useful. But we don't recommend it when the hemarthrosis is little, in a little hemarthrosis, when it's well controlled with coagulating factor, when it's not very painful, and of course, if the blood is already coagulated.
So it's only indicated in tense hemarthrosis, which are painful, then only you aspirate.
And
Okay.
liquid blood. And liquid
Yeah, of course, liquid blood. Then only you can aspirate. And finally, what's the role of intra-articular steroids injections? Do you recommend to be given in hemophilia? Because in normal osteoarthritis population, if you give steroids, that causes more damage to the joint, and so we normally avoid in giving osteoarthritis. So in hemophilic painful joints, do you recommend steroid injection?
Yeah, to us, a steroid injection, well, we use it from time to time, but they are the second line of treatment. For instance, in case of synovitis, when you cannot treat your patients with radiosynovectomy or chemical synovectomy, intraarticular steroids is an anti-inflammatory drug, and it can temporarily control the inflammation, the swelling in the synovium, and reduce the pain and the bleedings. But it's not the first line. And we also use it in those cases when sometimes when we use hyaluronic acid or other drugs for arthropathy, but when there is already a deterioration of the cartilage. In those patients that are many, that they have a very painful joint with no cartilage, with a huge deformity of the bone, in those cases we are not worried about the cartilage because it's already destroyed. And it also can be helpful to reduce pain. But as you say, please, both steroids and anesthetic drugs, intraarticularly, they are both of them chondrotoxic. So be careful in those patients with remaining cartilage.
And also it can, repeated injection of steroid can lead to neuropathic joints, So the sensations gradually becomes less and it becomes neuropathic joints. Thank you, Hortensia. And finally, Carlos, excellent study. I have one question that, do you do this therapy with your hinge knee brace to start with, then gradually you discard the hinge knee brace, or you start like that without the braces?
You mean what kind of the progression, sorry? Progression in regard to the intensity of the exercise?
Your muscle strengthening, in hemophilic arthropathy to reduce pain. Do you do it a hinge knee brace or without any
Okay,
brace?
I
Yeah,
see. Yeah. For instance, in the case report that I show you, the exercise was without any brace.
yeah.
But of course, if you have some patient with joint instability, could help to do the brace. The brace could be like a way to feel more confidence to the patient more safely in the exercise. So I think it's not a problem to do exercise with an external device to stabilize the joint. And of course, you can, in the time with the progression, you can release the external support to the joint. But anyway, here is to do exercise in a good way to give all this the support to the patient to feel sure about the exercise and safe. Okay.
Okay. And the next thing is the case which you showed, uh, whether the joint replacement should have been done first and then you improve on the muscles so that it would be easier because there will be it's a grossly destroyed joint, so you don't have a fulcrum to act there. So if you do a joint replacement first and probably then improve the muscle therapy, because it will be much more painless to do that after the surgery. What is your take on this?
Yeah, so we have case of patients that have like 5 years after total knee replacement can improve the strength, but the muscle must still be the same. So this is the reality. We don't know what are the main mechanisms that explain why it's too complicated to increase the muscle mass after surgery. But I think will be related with the chronicity before to the surgery, because if you wait like 10 years and you have 10 years of atrophy with a severe atrophy to the muscles, of course, the physiology of the muscle is totally different. So maybe you can increase the neural factors to increase the force, but the structure of the muscle will still be the same. So this is my perception. You can increase the strength of the muscles mainly in regard to the motor units. The motor units will be the main factors to increase the strength. And the muscle volume, we need to see in the future studies if possible to change. I think will be explain the strength, but it's not the main factor. Okay.
Okay, great. Thank you. Over to Greg for some other.
Yeah, I have the benefit of, as I look through the Q&A box, I can see who's asking what questions, and I can tell you the heavy hitters in musculoskeletal management of hemophilia from multiple continents have come out to join us today. So I think for those people that must be driving some of them crazy, they must be clicking and clicking on their unmute button to try to unmute themselves and not being able to. But I want to take us back to the topic or the idea of kinesiophobia. And I'll open this up to all of the panelists. If we take people with hemophilia as a population, should we be considering kinesiophobia for people who have arthropathy really to be kind of a normal state, as opposed to something pathological? And should we be managing that differently in terms of just building trust in their movement of their bodies, understanding mobility, to trust it, to live with that pain and how it impacts movement? And should that be different than how we might treat or how we would deal with primary chronic pain as a separate entity?
I don't know. Maybe Hortensia can complement the question, because I don't know the position of the medical doctor about the kinesiophobia, the fear to move.
Thomas, what do you think about that? I mean, is kinesiophobia really, is that just a normal state of being for somebody with a condition like hemophilia and arthropathy?
I think it has changed in the older population. We found this, and we have to address it. In the younger population, I don't believe that we have so many younger patients with this. But back to the older one, what we see also in our rehabilitation center and during our rehabilitation treatments, that more is possible, and that we have to bring the patients and the exercise treatment a little bit together and try what is possible. And Carlos has addressed it, to ask after the pain during this process and after the pain after this training. And what we see is in our rehabilitation program, as more as the patients are engaged in these programs, as more they are able to move and they can handle their pain with this. And this is our experience. And I would like, this is my answer of this question, but I would like, if it is possible, Greg, to give some hints also to the question which are asked from Dr. Mohanty regarding the eterocoxib, because they have spoken about etoricoxib as a COX-2 inhibitor. And I think it's important to know and to mention that this drug is a very good drug, but you have to check blood pressure, because our experience is that this drug is able to enhance blood pressure. And so it's not necessary after the first treatment to check it if it is necessary to reduce or whatever. This is one part. And the other part, what I want to address too, is the treatment with opioids. And in my experience, opioids are in many cases not really helpful in treating joint pain and joint diseases. So if you, and it's only possible to win a little bit time with it, and you have to think if this makes sense with this drug at the end, or if there are other solutions, maybe operation, whatever. There's some. I'm sorry for that, but I want to give some remarks to the question and the answers of the colleagues.
No, absolutely fair, and we appreciate that, absolutely. I agree with going back to that kinesiophobia angle. One of the things that you said in your answer to that, and I definitely agree with you, is the patient education piece. And Carlos, you highlighted that in the answer to your first question, and making sure that patients understand that pain does not equate to damage, and that it is not necessarily something that they have to be fearful of, but something that they have to manage and coexist with. Hortensia, you are a very proficient user of POCUS, of point-of-care ultrasound, musculoskeletal ultrasound. Do you feel that the use of that modality can have a role in helping patients really understand the impact of their arthropathy and the pain that's caused by it, and help them to manage it and coexist with it?
Yeah, great. Thank you for the question. Yeah, it's a very interesting tool to help patients to understand what is happening inside the joint, because many times the patient understand the pain, the atrophy, the limitation in range of motion. Of course, they need more education, as we are mentioning, but understanding better what are the particularities inside the joint, if they are bleeding, if they are, if the synovium is inflamed, if they are having microbleeds. This is something very interesting for them to have this feedback of the kind of pain they are feeling, because sometimes we are realizing that many patients remember and they know very well how a huge hemarthrosis feels, but they have difficulties in recognizing these new small bleedings, these new perceptions, these new feelings in the joint. And well, this is interesting for focusing better the treatment and all the enormous amount of options we have. It's not the same one kind of pain or the other. If not the same, if it's related to a bleeding, it's not the same if it's chronic with central sensitization. And so POCUS help us to identify better some of the problems of the joint pain.
Thank you. We have some folks weighing in on the Q&A box asking if our panelists have any experience with patients self-medicating their pain with agents, supplements, other things, and what your thoughts are on that, and what role you think it plays when the patients start to self-medicate with agents or supplements?
Well, we have experience because it's something natural. If the patient feel that the pain is not approached, is not treated, they will look for some ways to relieve it. And not only medication, they also use different options, and they also ask to other patients with hemophilia what are the solutions they have taken. But for this reason, it's especially important to don't forget to approach this conversation with our patients. What about your pain? Do you feel pain? How do you feel today? How have you been feeling the last weeks? What improves? It's important to approach pain to avoid this. But of course, we all should have cases like that. And if we don't know it, it's because we have not asked it. But naturally, people look for solution to their pain.
Carlos, there's been a fair bit of interest in the case study that you presented and the strength program that you had your client on. One of the questions asked about whether the strength program extended to the entire lower limb beyond just the motors of the thigh, or whether you were confining your strengthening work to just the muscles that you showed.
Yeah, in this case report, the program was mainly in regarding to start with isometric exercise. But when we think about isometric exercise, our thought is like contract your muscle without changing the angle. So, but in this case, using a biofeedback, you can really know what are the main force that muscle can do, like the tension of the muscles. So we progressed from isometric training, and then we combined with a close kinetic exercise on the knee with elastic bands. So sometimes you need to program 3 exercises will be enough because at the end, if you prescribe a lot of exercise for the patient, could be like confusing to remember the exercise. So I think in this case, I remember that we did only 2 exercises, main exercise in close kinetic change and isometric strain with this biofeedback device.
Okay, thank you. And we have just about 5 minutes left. Dr. Mohanty, did you have any final questions you wanted to ask before we turn it back over to Siani?
Yeah, just quick questions. There was a question also in the chat box. Now, how do you address the psychological component of the pain, which is a major aspect? All the panelists, they can just give a short answer before we move to Siani.
Well, very short. In our case, we have a psychologist in the unit, and we usually consult it when the pain is making the patient suffering in different ways of life. We consult the psychologist.
Is that everyone, consult a psychologist, or is there any other aspect? Thomas, what is your opinion about it?
It's absolutely the same. I agree with Hortensia. We need an interdisciplinary team, and a psychologist is one part of this team. It's hard to compensate. However, you have to find a team around yourself where you can ask with these topics there. It's absolutely necessary because especially in the chronic phase, chronic pain, it's absolutely necessary to treat it by multimodal therapy, and therefore you need it.
Okay, thank you. Over to Shani.
Yeah, Dr. Assad, he would like you to have some word.
Yeah, I have a comment, but also quick questions to the panel, which is not really related to the topic of today, but it's a hot topic that was discussed a little bit during the ASH last week. As some of you may know, that one of the SSE group at the ISTH is redefining the ABR now, And they are considering new, let's say, criteria in order to identify acute bleed. And they are a little bit under scoring or excluding the ultrasound in identifying acute bleeds, which is going to be a big step or a big things on what we do and what we've been doing in the last 10 years of, let's say, putting more focus on ultrasound. So what is the opinion of the panel here about that?
Well, as I wasn't in ASH, and I don't have this actual, this current information, but of course ABR is not a sensitive tool nowadays because there are many bleedings that are little, are not reported by patients or are subclinical. If they are subclinical, it's very difficult to be assessed by ultrasound or to be assessed by any method, because in many cases patients don't come to the center, and I don't know what options we have. Of course, ultrasound help us to understand better synovitis, that it's clearly a consequence, is an indirect biomarker of bleedings, clinical or subclinical. So synovitis can help, and maybe in the future, but not now, maybe in the future we could count with some other biomarkers, test blood biomarkers, but nowadays we are not in this point, more research is needed. So I don't know what they propose. If ABR is not enough, ultrasound is sometimes difficult.
It's redefining the ABR and excluding the ultrasound of one of the markers to identify acute bleeds, let's say.
But how do you redefine ABR?
I mean, for us, because we've been now in the last 10 years or more, very much focusing on the importance of ultrasound, which is, let's say, a very easy way, particularly with these handheld probes now, to identify more or to study more the joints during acute bleeds and for synovitis also. And if we really are not gonna or not gonna put more focus on ultrasound, that's going to be a big problem for many of this of the work that has been done and all this. That's my opinion, and we are really a little bit concerned about about this at the WFH. So I wanted, since we have big number of experts here, to just bring this and ask the opinion of the panel. Soon we're going to have more information about that, and I'm sure that we're going to have to do something through our MSK committee here. And we might next year have a call with the committee in order to discuss this, just to make sure we have a unified position at the WFH regarding this.
But I don't know if there are many options to redefine ABR, because ABR is a rate of bleeding, but maybe we can redefine target joint, that there are also some new definitions for target joint. This is an option, and maybe artificial intelligence could help us with this difficult task.
Yeah.
Who knows?
Yeah, so we'll wait until they have, let's say, preliminary report from this SSC at the ISTH, and then for sure, as the WFH, through the committee, we're going to have a call with the committee and other experts, like the people are here on this. Although you are not part of the committee itself, but you are part of the member at large in the MSK group. So that is going to be very important to have you all. And at the end, really, I would like to ask all the speakers who were here, and Dr. Mohanty, who did the panel here, was great. But the most important, I noticed in the people who are attending, Kathy Mulder, and I would like to acknowledge the presence of Kathy Mulder here, and just thanking her for her being with us today here and for all the work that she did during these years, either as a volunteer to the WFH or as a member of or chair of the committee. And this webinar brings me back in close contact with the MSK, which is a dear committee to my heart, because I spent more than 20 years working with the MSK committee. And I can see here that there are a lot of people that we didn't meet in the last few years. They are present here. Like Pam Hillard, for example, who was among the people who developed the hemophilia joint health score. Some names that also I've lost contact with them, like Samir Rahim from South Africa, Kauthar from Tunisia. I'm really very happy to have all these people with us here, including Paul McClellan from Royal Free London also. So I would like to thank everybody here, and on behalf of the WFH, and we are really very pleased with this start with the MSK committee. And we are going to be more than pleased in the future to have more webinars, because we believe the musculoskeletal aspects of hemophilia care are very important, and we need always to focus on this, because that's the way that we can have better joints and better life for the patients. Sian?
Thank you, Asad. Thank you, all the speakers. Thank you, the chair, Carla D'Afuncio, to make this webinar possible and invited all the panelists. Here is my email from the WFH. So if you have any questions, I can forward for the committed or for any others speakers. And I'm very, very happy for this webinar. So happy holidays for everyone. And we can see you guys again in 2026.
Sian, may I just ask for
Yes,
the people who
for
are
sure.
attending, if people wanted to watch it back again because it is recorded, is there going to be a way that people are notified that they can view the recording if they wanted to?
Yes, we have a channel on YouTube, and I can upload the video in a YouTube.
Thank you.
Okay. Okay. See you guys. Bye-bye.
See
Happy
ya.
Thank
holidays.
you.
Bye.
Thank you.
Bye-bye.
Bye.
Thank you.
Merry Christmas, New Year ahead. Thank you.